Good afternoon. It's just a little after 12, so we'd like to begin our program to give our speakers the maximum amount of time to speak. Welcome to Zella Hall Ethics Lecture Series. My name is Sister Miriam, and I have the privilege to serve as Vice President for Mission and Ministry at St. Vincent Charity Medical Center. Welcome to our 2020-21 Zella Hall series entitled An Ethical Look at Behavioral Health, Perspectives During this Troubling Era. We are excited about this year's topic as it addresses so many of our concerns and areas of growth we are undertaking this year, especially in behavioral health. We continue to do our program by Zoom. Please be sure you are on mute. Hopefully you have registered by yourself and not in a group, so we have your name in for attendance. And in that way, you will also receive your evaluation form to fill out and return to Sister Jane as quickly as possible. So let us begin. And we will begin in prayer as we do all things. Blessed are you, God of all creation, whose very life permeates our world, and whose goodness fills our hearts with joy. Blessed are you, who have brought us together as friends and colleagues. Be present to us, continue to work in us the wonder of your grace, forming us as your people committed to justice and mercy, healing and compassion, communication and affirmation in a world burdened by violence, injustice, and indifference. Pour forth your blessing on us, renew and refresh us for our mission at St. Vincent Charity Medical Center, making us effective leaders and wise stewards of your bountiful gifts and compassionate caregivers. Bless this Zella Hall Ethics Series and all the speakers that they share with us their passion for caring for the sick, especially those with behavioral health issues. May this time strengthen the bonds that unite us in love and faithful service. We ask this through Christ's name, amen. Now you all know about Zella Hall. You have heard this before. Zella Hall is named after a woman, Zella Hall, who was a patient, had excellent care, and wanted to reward us. And by doing so, she left us money that we could start an ethics series, a monthly series, offering excellent speakers to our residents here at the hospital. This year is different because of the coronavirus and how that has an effect on us. So we are in the Zoom mode for doing our presentations. Please be patient with us as we transfer from place to place for the different speakers. The theme this year is an ethical look at behavioral health, perspectives during a troubling time. Today's topic is the revolving patient, integration and care coordination as solutions to a complex problem. We have three great speakers for today. Dr. Michael Biscaro, a doctor of psychiatry, and he is our Chief Behavioral Health in Rosary Hall doctor. Next will be Megan Bush, who is a social worker with an extensive background in psychology and communication, and is presently our Director of Behavioral Health Access and Intake. And our third speaker today will be Annie Ferris, who is an acute care nurse practitioner, also working with our integrated care program for behavioral health. We are blessed here to have such great people working with us and speakers for today. And now I would like to turn the Zoom over to Dr. Biscaro.
Thank you, Sister. Pleasure to be here this afternoon and on the web with you all. Hopefully you can hear me, and I can see Annie. So Annie, give me a nod if you can hear me. All right. So today we're going to be talking to you a little bit about the revolving patient, care coordination, and treatment integration techniques to solve a complex problem. You know, the problem, these are problems that our patients experience. They have a number of complexities, but I think what we'll also probably elucidate here is that there are a number of system problems, I think, that cause difficulties for our folks who experience co-occurring mental health challenges, addictions, and then medical comorbidities. We're going to spend a little bit of time talking about this phenomena of the revolving patient, different ways that the system of care can minimize recidivism. That's really what we're talking about here. Talking about a couple different ways and a couple different interventions that can be used to improve client outcomes. And really, we want to spend some time talking to you today about what we're doing here to address this issue. And Megan is going to do that, talk specifically about some of our expansion. And then Annie will talk with you about a specific case to sort of highlight how these integration practices, the things that we're doing here, are going to help our folks improve and likely improve quicker than if we were treating them in more traditional ways. Now, of course, I'll start with giving the overview and talking a little bit more just about some of the theories and principles behind really integrated care. So there are the objectives. Recidivism and the revolving patient. I think it's important to talk a little bit about the meaning of recidivism. Most people know what that means. It means coming back to care. It's a return to kind of, it's actually, if you look up on Webster, it says a falling back into quote unquote bad habits. We also hear about recidivism in terms of like a reoffense or a rehospitalization. You know, really, if you look at it, I think recidivism, it tends to, maybe not always, but I think there's an undercurrent and an undertone of blaming the patient, blaming the person. Really, what I think that this is a more of a systems-based problem. I think that there are a lot of things that we can do as treatment providers in a treatment system to impact recidivism. That's kind of why I like the idea of the revolving patient versus using, or the revolving, this kind of revolving, either revolving patient's not even the best term, but this idea of somebody kind of, you know, in a revolving door. If we look at the person as the door, the people that are coming through that door, the treatment system, the providers, those are the people that are acting. It's not really the door's fault that it's spinning around and around. It's all of those things that are acting upon it that keep it spinning. If you want to use that as an analogy. And I think that that's a good way to think about it, because in a lot of ways, it's not the door's fault. We need to figure out things ourselves as both professionals and as a care system to help minimize this particular issue. Okay. So the scope of the problem here, and if you have seen or heard from me before on this topic, you may have seen this slide, but I think it's really important. People with mental illness die much sooner than those people, you know, who do not have those conditions. More than 2/3 of people with mental illness have one or more chronic medical conditions. 1 in 5 of adults with mental illness have a co-occurring substance abuse condition. And we know that as high as 50 to 75% of people with more serious mental illnesses also have co-occurring addiction. So mental illness, if we think about it in terms of a continuum, mild and moderate and severe, as you have more serious, more persistent mental illness, the likelihood of you having co-occurring addiction, co-occurring medical complexity goes up and up and up. Here's just another way to show that. This is an oldie but goodie graph from JAMA. that really shows how people with mental illness experience addictions and how it co-occurs. It kind of shows exactly what I just said. The general population having an addiction at around 16%. If we think of panic disorder, depression, and OCD as more milder mental illnesses, still at a higher rate than the general population, but certainly not as high as people with schizophrenia spectrum disorders or bipolar disorder. Again, just kind of elucidating or kind of proving, emphasizing that point that the more serious and persistent that mental illness is, the more likely of co-occurrence and the more likely of co-occurring medical complexity, which the next graph here is going to show us. This is a slide from the SAMHSA HRSA, HRSA Center for Integrated Solutions. It shows obviously there's many comorbidities for folks who experience mental illness. High blood pressure, high rates of high blood pressure, diabetes, smoking, obesity, and heart disease. It really shouldn't be much of a surprise, though, given a lot of the health behaviors that are demonstrated by this population, the poor access that they have to resources, their inconsistent use of healthcare and follow-up plans, and really also our approach to them. Our traditional healthcare system is, or our healthcare system is rather traditional, and it kind of expects people to come to them, keep multiple appointments, and for a population that's complex, that has limited resources, that quite frankly struggles, this is a hard thing to achieve. A little bit about people with serious mental illness and co-occurring addictions. It's important to note that many of these folks, especially if we're talking about schizophrenia, spectrum mental illnesses, folks have a neurobiological predisposition that leaves them vulnerable to consequences of addiction, that leaves them vulnerable to having difficulties with decision making and thinking clearly. I think that's an important thing to know. As a result, they require longer term treatment. They have more crises. They progress more gradually in treatment. Traditional treatment approaches aren't as effective, and they really require more recovery-oriented relapse prevention models to help them succeed. When we're talking about people with multiple behavioral health disorders, and primarily we're going to be talking about people with serious mental illness and co-occurring addictions, it's important to know that understanding and ruling out dual diagnosis should really always be our expectation and not the exception. We really should be paying special attention to what conditions they're struggling with, to what degree, so we know how to approach them. Both diagnoses or all diagnoses, in my opinion, should always be considered primary. You'll hear primary, secondary, tertiary. That's not really a medical concept, that's an insurance concept. And what we want to be doing is providing good care, not insurance care. Some of my staff have certainly heard me, folks on my team have heard me say that. The idea is to really make sure that we're treating everything as primary, everything's important, and everything deserves to be addressed fully and completely. Simultaneous treatment for this population, again, we're talking today about people with serious mental illness or mental illness, co-occurring addictions, and medical comorbidities. Treating all that stuff together is really important. And typical treatment, meaning if we're just talking about, we're just treating a substance use disorder, or we're just treating a primary care issue, or we're just treating mental health problems, all of these things require modification if other things exist. For example, if we're in primary care and we're treating medical issues, but that person also has a mental illness and or an addiction, we should be doing some things differently. Conversely, if I'm seeing somebody with depression, but I also know they have an alcohol problem, I'm not just going to treat them for depression. I need to be doing some things differently if they also have an addiction. And we can keep going, right? If they have all three, then we definitely all need to be working together in concert to be addressing those things thoroughly and completely. Again, the traditional approach to a lot of treatment tends to be, we're treating each disorder separately, and it tends to be either parallel or sequential. Parallel being we're treating things side by side. They're coming to me as their psychologist, they're going to Annie as their nurse practitioner, and they're going to somebody else for their mental health problem or for their addiction problem. That's parallel. They're doing this all at the same time. It could be at the same agency here, or it could be actually 3 different agencies, which we could spend a lot of time talking about, which oftentimes happen, especially in community mental health or in the public sector. And these folks tend to have a lot of difficulty with that, but that's how we're set up. Sequentially, again, is, I'm a lot of, folks who have been in the field, especially in mental health and addictions field, are probably familiar with this, right? You've got to get your symptoms under control before you can get sober, or, you got to get sober before you can get your symptoms under control. So it's kind of this idea that you got to do one thing first and then you're going to do the next. Separate treatment's not effective. We've proven this. This has been proven over the years. It's why we have problems with recidivism to begin with, especially in this population. And we need to start, and that's why integrated treatment, that's why this idea of bringing things together, same time, same location, same team, has really become ultra critical. So I've kind of let it out of the bag here, but really the solution is this integrated approach. It's the most effective way to care for people with mental illness, addictions, and chronic medical problems. When those things coexist, really the best way and really the only way to guarantee better results is to do this in an integrated way. The reason is there is much more of an emphasis and an integrated treatment approach on that serious and persistent mental illness, that co-occurring addiction, and that increased medical complexity. Everybody kind of gets it, and they understand what the person's going through. They make an attempt to understand what they're going through. It's person-centered. It's really focused on what that person's needs are. We all have a more complete understanding of what that person's goals are, what they're working towards, what the plan of care is. And it's really also about just mind, body, and spirit, really attending to that entire person. Just put another way, according to the Institute, the NIMH, integrated care is about everything that's being in one setting, blending all the available expertise. It's not separate, it's team-based. So really, what's different about integrated care? It's really, it's a fundamental shift in the process of care. We can think about it as traditional care compared to collaborative care. So in traditional care, we're assuming that knowledge drives change. If we just educate them, if we just tell them what to do, then they're going to change and get better. Yeah, well, we know that's not always the case, right? In a collaborative care, it assumes that knowledge and confidence drives change. What do I mean by confidence? So the person knows what's going on with them, believes they have a problem, is invested in change, and has some ability and some know-how how to fix it. It's a big difference. The clinician sets the agenda in traditional care. The person sets the agenda in collaborative care. You can see the slide. I don't have to go through each of these points. I think an important thing also to know is that decisions are made collaboratively in collaborative care. And there's a focus more on the person's needs and goals in an integrated or collaborative care model versus focus on problems and symptoms. We do need to know what a person's problem is in order to kind of help fix it. We need to know their symptoms. But typically in this population, if you fix one thing, there's usually a whole lot more things that need to be addressed. So you really need to be aware of those. So why do we integrate care? Like, what's the point? We need to do that because people are complex. Mental health and substance use disorders co-occur at pretty high rates, usually around 50% or more if you have one or the other. There's usually some co-occurrence there. And like we said earlier, if you have more serious and persistent mental illness, it's likely that even higher that you'll have a co-occurrence. There's more medical, social, and emotional problems. These folks, this is kind of a pretty well-cited number that they die about 25 years earlier than those people who don't have those conditions. So if you have a mental illness, serious mental illness, a co-occurring addiction, and or additional medical complexity, your lifespan is, we know it's shorter. You also have an increased vulnerability to relapse and decompensation. So why do we do this? Well, there's a cost to not integrating, treatments and not doing things in recovery-oriented ways. We tend to see cycling. We're talking about the revolving patient, the revolving door. If we're not addressing everything, they're going to keep coming in. If they're not invested, and if we're not doing things to help them get invested in their care, they're not going to do what they need to do to be well, and they're going to keep coming in. This causes some demoralization, right? We start to hear words like, this is the frequent flyers, these are the people that are crazy, the schizophrenics, the addicts. Because we're not seeing people get better, we get a lot of, especially staff and system demoralization. That causes system decay. Treatment's not as effective because we lose staff. People don't want to come in, people don't want to come where they're not seen as people. What does that do? Well, that means that we continue to have more illness. People die, they don't get well. I promise to make it get better though for your Friday. We don't want to leave it at that. One way to look at cost. One way to look at this also is, there was a study that was also put out by SAMHSA that showed individuals who were treated in an integrated way had fewer nights being homeless, had 50 fewer hospitalizations, had fewer nights in detox, fewer ER visits. And this all equaled $2.5 million in savings for this group of individuals that they studied. So not only does it improve lives, it saves lives and reduce costs. That's a pretty good deal. Want to go over some principles of integrated treatment. So integrated treatments tend to be person-centered. They're collaborative. We've already talked a little bit about what that is. They're population-based, meaning people don't fall through the cracks. We monitor what's going on with the panel and the population that we're treating. We measure and tailor our treatments to particular targets. We use evidence-based treatments to make sure that we're doing the things that are known to be effective for that particular condition. For example, people with co-occurring disorders, substance use, mental health. We know that the treatment that's effective is an integrated treatment approach. So why would we continue to do separate or sequential or parallel type treatments? Integrated treatment is also accountable. Providers are held accountable. They're reimbursed for quality. They're reimbursed for good outcome, not just the volume of care that they provide. Okay, so volume is great, but if you're not helping people get better, if you're not producing quality outcomes, that's a problem. I'm going to go over some key treatment integration principles, and then I'm going to try to do this a little quickly so then I can turn it over to the other presenters. These treatment principles come from integrated dual diagnosis treatment, which is an evidence-based treatment for people who experience serious mental illness and co-occurring addictions. The reason why I'm sharing these treatment principles is because if you look at different integrated treatments and integrated treatment approaches, these principles and this philosophy is pretty, universal. It boils down to being this, again, the same team or the same teams, the same location, and the same time. We're doing this all at once versus them going all over the place. So first principle is integrating substance abuse and mental health treatments. This is the same clinicians in the same program being cross-trained to be able to work with individuals no matter what they come in with, no matter what they're wanting to address. We need to have, obviously, then flexible and specialized clinicians, people who are capable of either cross-training the other staff or working a little bit outside of their traditional roles. Integrated treatment approaches also require assertive outreach. So you're going out and getting them. You have systems in place that can make sure that people are reminded of and or can get into their appointments. You provide intensive case management and care coordination. Integrated treatments also really hold and really value client preferences. So this idea of being, client and person centered or culturally sensitive. I'm going to catch up to myself here. Again, if we're recognizing people's preferences, there's better engagement and they feel understood. They don't just feel talked to, they feel listened to. Close monitoring. If we're closely monitoring them, we're likely to increase adherence. If we're visiting them frequently, we know where they are and they hang out. They have multiple touch points on our team. For example, in our new clinic, they could be seeing a therapist, they could be seeing a provider, a medical provider, and they could be seeing a peer supporter. So there's going to be multiple touch points in that clinic. We're going to be monitoring them. We're going to know what's going on. Integrated treatments are comprehensive, meaning you have case management, you attend to the family's needs, you attend to the individual's needs, both individually and in group settings. You provide the range of services that a person would need given the population that you're trying to serve. And then, of course, you're also trying to do these 4 things. You want to make sure that people are in stable living conditions so that they're safe. It's hard to work with people if they don't feel safe, if they don't know where they're going to stay tonight, and they don't know when their next meal is coming to them. These are just some of the basics, right? Integrated treatment is a long-term perspective. It's time unlimited. A lot of our kind of acute or problem-focused treatments tend to be very time limited. And we know that people are complex. Change happens over time, doesn't happen overnight. And so integrated treatments are time unlimited. They're also stage-wise in their approach. So what do I mean by that? I could spend an hour talking to you about stage-wise treatments or the stage-wise treatment approach. But really what this means is that our approach, what we're doing, matches their readiness, okay? We aren't assuming that they're ready for change. And this is really a big problem. A lot of our traditional treatments are set up to expect people to be ready and want to change. And we so know that to not be true, especially in this population. You really need to sort of figure out where they're at and start there, because that's where you're going to get some engagement and buy-in. Last but not least, it's optimism. Who changes if they feel like there's no hope? But optimism is feeling supported, feeling hopeful that there's some agency, and that creates the agency for change. Again, I just wanted to say a little bit more about integrated stage-wise treatment. I'd love to talk to you forever about this, but again, stage of change. Many of people have heard of Prochaska and DiClemente's trans-theoretical model of change, but pre-contemplation, contemplation, preparation, action, maintenance. That really is about somebody's internal motivation and readiness to make a behavior change. How they feel inside, how they think about their issue. So that's stage of change. Stage of treatment, which I was referring to earlier, stage-wise treatment is really about our approach. It's taking both a person's internal readiness and kind of mapping that onto their relationship to us and what we're doing with them. So this is where we get into things like we're talking about engagement. So what are we doing? This person's really not ready to even be kind of talking about change, and they're not even necessarily wanting to be with us. They barely coming in. So how are we going to engage somebody? How do we help persuade or motivate them? What do we do when they're ready? And then that action stage of treatment, or that active treatment stage. And then what do we do once we've gotten them through that learning, and how do we help prevent relapse and maintain that change? So I hinted at this, but why use integrated principles? Because we know they're more effective than separate treatment. There is a study by Drake, O'Neill, and Wallach back in 2008, 45 different controlled studies on how integrated treatment was more effective than the traditional approach. If that doesn't convince you, a study out of New Hampshire that showed that persons with dual disorders, if provided integrated treatment or parallel treatment, and how they did. So the blue line represents people who received integrated treatment. Red line received more traditional treatment. Obviously, over 4 years, we see that more than 60% of those who had integrated treatment achieved and maintained remission versus 20% of those people who received traditional treatment. I know which one I would want me or my family to get. So we know if we keep people, especially people with serious mental illness, co-occurring addictions, and medical issues, if we keep them engaged in treatment, and if we keep them abstinent, if we keep them mentally well, or as mentally well as they can be, that's going to lead to less hospitalizations, fewer symptoms, suicides, fewer episodes of violence, legal problems, better physical health, improved functioning, the ability to work, and improve relationships both with others and their family. So really the key here starts to become is, well, how do we accomplish this? Well, at St. Vincent's, we needed to kind of come up with a few initiatives in order to pull this off. So we needed to expand outpatient services. We really needed to move from acute care, especially in behavioral health, to complete care. So this idea, and I'll kind of show you what I mean by that here in a quick minute. We needed to have a panel of providers that could integrate care. We needed to have peer recovery supporters and other staff that could really help aid in coordinating care and getting people to where they need to go. We definitely also needed to have a more robust and more intensive treatment options, given the range of complexity of the people that we serve. Again, so what all of this ends up doing is really producing a full continuum of care, where at the most acute levels, we have our psychiatric emergency department, our inpatient and detox unit. At the more kind of middle or moderate range, we have our intensive outpatient treatment programs here at Rosary Hall, where I'm sitting. And then obviously we have our base, of outpatient care, which we now have over in our integrated care clinic, where we offer outpatient mental health, trauma, and wellness services over in what's called the MOB. We are, and Megan's going to kind of get into that here in a minute and just talk to you a little bit about the expanded care team. And just some of the different initiatives that we have going on. But really, this full continuum of care, again, it helps keep people out of the most costly, intensive levels of care, inpatient psychiatry and detox. It also helps them live healthier, more productive and meaningful lives. So now I'm going to turn it over to Megan, who's going to talk with you a little bit more about our expanded care team, and some of the different things that we've been doing here in behavioral health to get close to and fully fulfill this integrated model.
Hi, good afternoon. So, to build the team to provide the services that Dr. Biscaro has kind of teed up here, we realized that we really had to take into account all of the different kinds of treatment settings, levels of care, populations that are served both in the hospital and throughout the medical group. So the team compositions that this slide outlines are really needed to be flexible and kind of varied. And we also realized that whatever providers we brought on had to both be embedded somewhat in the hospital and go to these clients where they might be, going back to that principle of assertive outreach that Dr. Biscaro referenced a few times. But then also we had to add some services, expand our service line to meet the needs of maybe higher functioning or downstream clients. So this grid represents 4 different kind of team compositions. The hospital peer team, and I would probably also add in there the expert team that we'll talk more about. That's really the only one that is exclusively almost exclusively placed in the hospital setting. So on various medical floors, on the inpatient behavioral health floors, and they're really in there, again, bringing the behavioral health component, doing some screenings that I'll talk more about in just a few minutes. The other 3 teams are our outpatient teams, and they have various purposes, but generally speaking, they're either represented in the healthcare clinic, the HCC, the new outpatient clinic that we've opened over in the MOB, or our outpatient Rosary Hall. And the key really is that it's they're comprised of folks that bring different specialties, both in their experience with treating various diagnoses, but also in their roles and what function they can serve with our clients. So you'll notice that LISWs, or really which are therapists, counselors, are combined there with prescribers, sometimes RNs, case managers who are doing more of the kind of social skill building or linkage building, community kind of based work for our clients, care coordinators, which is a lot of those linkages, and then peer supports. So I think that and another thing to keep in mind then is, as we started hiring these providers, the interview process was very much based on if the individuals were bringing to the table an understanding, hopefully some experience in, but definitely a value for integrated care and what that means. So not just have they treated and do they treat mental health and substance abuse concurrently and understand how they exist, how they coexist together, but also recognizing like the holistic health of an individual. So mental health, physical health, spiritual health, social health, safety, so that we had a team that's really kind of operating under the mission that we're trying to create here. Okay, next slide, please. So primary care team objectives, one is to, I think primarily with this expansion and embedding some of the behavioral health into different hospital and outpatient settings that it hadn't existed before, is to just simply identify unmet needs and figure out how to fulfill those, right? So again, we'll talk a little bit more in a second about the expert team, but their role is really to go in, chat with people who are getting some kind of medical service or primary care service, and do just enough screening to recognize or help the individual recognize that they might be able to benefit from some behavioral health services, because those individuals might never take themselves into a therapy office, right? So again, getting out into the milieus and identifying unmet needs. Improving engagement in services. So that would not only be improving engagement in behavioral health services, but also whatever the primary services that you met them in. So an example, a great, really kind of concrete example is primary care. If a doctor could be working with someone on a chronic condition that they're just not seeing improve, diabetes, hypertension, obesity, by bringing in some behavioral health and recognizing maybe there are just some like health behavior changes that could be made, the person struggling with some underlying depression that's impacting their ability or willingness to make some of those health lifestyle changes, that then will make them have increased engagement in their primary care services as well. Of course, easing the transition. So we talk about how really the key to integrated care is making all boundaries really permeable throughout the hospital and the medical group. So part of our role in the integrated care team then is having someone that's going to help with those kind of warm handoffs. It's not simply telling a client you're discharging from this unit and you can show up over in this unit in a week. Instead, it really is trying to, when possible, if the client can see the face of who they'll be meeting in a week, can they somehow be walked over there so they see where they'll be going? What's that care coordination to really improve the client experience? And then, of course, to just improve overall health outcomes for people that we serve, both, again, focusing on physical and mental health. Next slide. Next slide, please. So what does it look, high level overview, what integrated services look like here? Again, on the hospital side, it's really bringing behavioral health into the medical units. So that's represented by Expert, which I know I keep teasing you, but we are going to talk about in just a minute. The healthcare clinic already has quite a decent integration you may not be aware, but there's already a medication-assisted treatment program that operates out of the HCC. Medication-assisted treatment is for folks struggling with addiction that are going to be treated with either Vivitrol, Suboxone, or Sublocade. So that's already taking place there. We just recently opened a couple afternoons where Dr. Biscaro and Dr. Spieth from Rosary Hall will be having some outpatient clinic hours, and then experts also in the HCC. And then on the outpatient side, it's the new clinic we opened in the MOB, which I'll dive into more details about here in a minute as well, and working with our primary care offices. Next slide. Maybe I should give you like a high sign or something. So to talk about SBIRT here, the primary objective is, again, identifying a need that would probably otherwise go unmet. So getting to folks in settings that that they're going to, but not primarily for addiction or mental health, and giving them very non-threatening kind of screening tools that might indicate there's another issue they're struggling with that we could be helpful with. Primarily looking at, again, alcohol and drug use, depression, anxiety, and trauma. So this kind of reiterates, again, same goals that integrated treatment as a whole has. So if we can identify a need that they have that's not being met, it will, of course, naturally lead to them improving their engagement in the other services that they're involved in. Next slide. Okay, these are the screening tools that the SBIRT team uses. So what's nice is, along the lines of integration, is that our SBIRT team right now is on the 5A and 5B. They see those patients, and then they're in the HCC. At the end of the month, we're meeting with occupational health. I think we'll hopefully get someone scheduled over there, and we're currently working out how we can be most helpful to Dr. Anderson. He's one of our neurosurgeons, his patients. And so on the medical floors right now that they're on, they actually are already partnering quite well with the nurses and the MAs. So the MAs have a couple preliminary screens that they give every client that comes on the floor. If the clients answer yes to certain questions, they meet the scoring threshold, a notification is automatically sent to our SBIRT team so that they know to go meet with those clients. And then they're providing these screens that are represented on your screen. So you can see it's a good mix of looking for, measuring for issues with both mental health and addiction. Next slide. Okay, so moving on to the healthcare center, as I referred to a few minutes ago, really brand new, just a few weeks ago, behavioral health started opening a couple afternoons for outpatient counseling hours. So it's primarily Dr. Biscaro and Dr. Spieth who are over there able to see clients on an outpatient basis. They, in the healthcare center, those services, the behavioral health services, are really going to be reserved just for clients that are already being seen by residents in the healthcare center for their primary care. So it's the referral has to come through a Meditech consult referral, and the HCC does the scheduling for that. The goal here in the mental health services in the HCC really are going to be meant to be pretty short term. So maybe someone that's struggling with what we might call like an adjustment disorder, so some major stressor happened in their life, or maybe they just got a diagnosis that they just kind of need to like work through how to adapt to. That would be sort of the ideal client for the HCC. Hours are listed there at the bottom of this screen. Next slide. So again, this is just, and I'm recognizing the time, so I'm going to try to talk a little faster here because Annie still has to go. But some examples of folks that might be ideal. So maybe a little bit of a further assessment. You're not sure if someone needs a higher level of service. You can send them over there. They can meet for a few sessions, and then Dr. Biscaro, Dr. Spieth can decide if they really should be referred to our ongoing clinic in the MOB or to Rosary Hall for more intensive services. Seeing someone in the medication-assisted treatment clinic over there that seems to be struggling with some mental health issues. So again, clients that are already in the HCC. Next slide, please. And this is what we've referenced. Okay. So the new clinic over in the MOB, which is in Suite 200, is a little over a month old as well. We're very excited about it. We're building this to be what we would hope is sort of a true integrated environment. So currently, the staff over there includes a psychologist who's the clinic lead. His name is Will Ajayi, an independent social worker. Her name is Marissa Norden. And then we just hired another independent social worker by the name of Lily Trimble. Those are the 3 counseling providers. Lily will be splitting her time between office-based and community-based care. So she really specializes in SPMI, severe persistent mental illnesses that someone is going to be struggling with throughout their life and maybe struggles even with basic needs, which is why she's able and willing to go into their homes in the community. Then Will and Marissa are going to be more office-based and working with folks that maybe struggle more with traumas, depression, family therapy, things along those lines. Ultimately, we want this clinic to be able to serve really the full continuum of mental health, mental illnesses. So folks that are high functioning and maybe just, what we might call the worried well, to folks that really have multiple struggles and need more of a wrap kind of support. We also have a peer support over there, Melinda Davis. So she'll be hooked up with clients. Any client that, again, needs just a little bit more than therapy will meet with Melinda as well. And she'll be doing more of the skill building, community skill building around life skills. We will have groups that we'll offer there. The exact groups we're offering aren't identified yet, but we know for sure we'll be offering some trauma groups, family systems groups. There may be some mindfulness-based groups, especially for folks maybe struggling with medical procedures coming up. We, of course, will treat dual diagnosis folks. If the individual primarily needs help with their addiction, they will still be Rosary Hall patients. But if they've got dual diagnosis, we can, of course, see them in the integrated care clinic. Down the line, we'll be offering primary care, as well as, I know Will has already been meeting with our, the chaplain group, pastoral care group here to see if they'll offer some groups as well. Last but not least, Annie Ferris is the nurse practitioner who's in that clinic, and she serves, her specialty and background is pain management. But she has really a wide scope of services. So right now, one thing we're really excited about is she's offering an opioid weaning program. Folks that have maybe been prescribed opiates for a long time really would like to get off of them in a safe way. She's treating them. She also treats psych patients who are maybe patients who are on prescribed psychiatric medications, but are just interested in some maintenance therapy with a prescriber. And then she'll also be taking ongoing patients coming out of our MAT clinic in the HCC. So she wears several hats over there. So again, patients that would be ideal for that clinic, full gamut of psych, people that need longer term treatment, dual diagnosis. That's it. Okay, next slide. And then to make an appointment for this is the main access to care number. So 363-2580, option number 2. I'll turn it over to Annie.
My turn. Can you hear me? Okay, thanks. Sometimes I have issues. So I'm Annie. Thank goodness I speak quickly. The way I like to introduce myself to patients is that I'm not a psych NP. I do not do primary behavioral health, but I also do not do primary care. I'm not here to steal your patients. I bridge the two together, take care of the whole person and make sure nothing's falling through the cracks. And a lot of that whole person care is the wellness, is the chronic pain issues, sleep issues. As Megan mentioned, opioid weaning is a passion of mine. So there's a whole gamut of things that I like to help take care of. And if I can't figure it out, then I help to make the appropriate linkage to care. Next slide. So the case that I want to talk about is Mr. Beebe. So 69-year-old gentleman, past medical history of hypertension, obesity, and previous smokers. So some of those chronic diseases that we were mentioning earlier. He was very clear to me. He has no history of behavioral health issues, but he presented to his primary care towards the end of the summer. He had presented once, a month later called again, a month later called again, all with vague symptoms. He just didn't feel well. There was a traumatic family event that had happened. And there was maybe some discussion about a little bit of wellness, but nothing concrete. They were able to do the SBIRT screening. His PHQ-9 was 0. They actually only did the PHQ-2, but his GAD, his anxiety score, was a 9. Next slide, please. So the primary
Your sound is out. I'm sure somebody's told you.
Can you hear me now?
Yes.
Yep.
Okay, thank you. My computer does this, I apologize. So I ordered some lab work on him, started him on vitamin D and magnesium, offered, so again, patient-driven, offered omega-3s. He said he takes cod liver oil, so I said that was fine for him to continue that. Referred him to counseling. We discussed sleep habits, mindfulness. He likes to play table tennis, and we discussed his diet. He admits he eats a lot of processed foods, a lot of sugar, so we talked a little bit through that. Next slide. So he called actually only a few days later, said that he couldn't tolerate the Zoloft, tried it at night, tried it during the day. He just wasn't going to take it. Went to his counseling session, said that he really appreciated that, was starting to feel slightly better. Brought up the numbness and tingling still, which I felt was more of a somatic presentation of his anxiety, not quite nerve pain related. We talked about we could add more medications, trial another one or hold off. And he said he enjoyed his counseling. He wanted to hold off. So I reached out to the primary care provider, discussed his blood pressure medications, which can have some of these same adverse effects. So that's part of that integration, is having me reach out to the primary care, make sure that we're doing everything that we can to control the patient's symptoms. So they got in touch with the patient, adjusted the medications a bit, and he went on his way. Next slide, please. Another 2 weeks later, had further counseling sessions. He was happy, improved energy, functionality, was sleeping great with magnesium and the mindfulness. He said at that time he would like to try another medication. So we landed on Cymbalta to try to address the neuropathic symptoms he was explaining. And again, continued the discussions more so around nutrition, continuing to find joy in playing table tennis. Next slide. So after 3 months, because he was happy with the medication, he tolerated it well, he has continued his counseling. I saw him last week. He's extremely happy with his progress. Said that majority of all of his symptoms are gone. He's sleeping well. His friends are jealous that he's winning at table tennis all the time, and they all want referrals to see our service. So I think that's pretty funny. I'm going to add that to my resume. But he's happy with where he's at. And within 3 months, we were able to go from this anxious, nervous man because of this family traumatic problem that happened to counseling, just a little bit of medication, some improvements on his sleep, and he's happy again. So it was a quick turnaround. Next slide. I think that's it. Any questions?
And I think that's a good case because it's not necessarily somebody, you know, that has, you know, schizophrenia or bipolar, but it's, you know, I mean, I think what it's showing is what we can achieve if we see people a little more frequently, if we focus on a lot of different things. And maybe if all he's seeing is his doctor who only has a few minutes with him, and that could have gone on for months and months. Right. And,
right. So it's not the most severe example I could have given, but it's a quick and dirty, you know, this is all that we can do and all the branches we can reach out to.
Yeah, so I think this is a point where we can open it up. I think we only have a few minutes, so sorry about that. But if anybody has any comments or question, maybe a question about something we said or the case or whatever, I guess now would be the time to do that.
This is Tom Strauss. I just want to say how important this work is you're doing right now, not only for our community and our patients, but really for the country. So congratulations, and we look forward to watching your success.
Thanks, Tom. Appreciate it. Anybody else have any questions, comments, anything about services that we can clarify? We just did such a bang up job that you don't even have any. That's fine too. Are there anything in the chat? I should look and see if there's anything in the chat.
So there is a schedule for behavioral health patients. That was a question from Heather Lindsay.
Okay.
Megan posted the phone number. If you can go back, Dr. Briscaro, a few slides. The 216-363-2580 is the central access option 2. And we are seeing patients in the MOB 200 Monday through Friday. And then HCC hours every other week, or Wednesdays and Fridays, depending on the week. Are there future plans to partner with the Diabetes Center? I would love that for the nutritional education, yes. And for clients who maybe we're not seeing the changes that we want to see, maybe need a little bit more oomph in their care, we would like to include them in our services, yes.
Yeah, so if that's you, Bev, you can just reach out to any of us, and we'll try to do whatever we can.
I do get a lot of referrals from podiatry. I try to work closely with pain management for injections. There's another question from Heather Lindsay. Is there also a plan for holistic care services in the future? Dr. Briscaro?
Well, I mean, it would depend on, you know, what you're meaning by holistic. But I think I would expect that the staff over there are going to be looking at really any and all sort of modalities we can use to help people find their path to recovery, healing, and wellness. And I don't mean that as just kind of jargon. I mean that seriously. I think that if you have ideas, if you think that we need to be looking at certain things, or if you have community connections and we can partner with people, then we're gonna do that. I tend to feel like at least we are in the early stages of embarking on whole person or holistic care. But if you're talking about things like, you know, yoga and acupuncture and alternative, you know, methods as well, I mean, the sky's the limit, quite frankly. We're limited by our imagination, or really limited by our, you know, our imagination. So, yeah. But
Yeah,
Heather,
I would just echo.
I was gonna say, Heather, if you've got some ideas, just, you know, let us know. Go ahead, Meg.
I would just echo sort of what Dr. Briscaro said, both to Bev and Heather, meaning we have a lot of ideas for bringing in some alternative therapies and holistic care, but we welcome anyone to shoot me an email if you have a specific idea or see a need in the population you're serving, because then we can, we'll move that to the top of the list.
Okay. Yeah, and I know Sherry Hostetler is on here, so Sherry, don't get mad at me, but we've got some good therapists here, like you Heather, who does art therapy, and occupational therapists, and so we'd be willing to talk to any of you if you're interested in helping us out, but just not too much. I wouldn't want Sherry to get mad at us for stealing your time. Anything else? We're done on the chat. We've got all those. So, sister, back to you guys.
I'm trying.
There she is. Yep.
Okay. Just talk. Okay, this is Sister Miriam. I'm just trying to close up here. It's after 1 o'clock, and I want to thank our presenters today for excellent presentations, really good examples of how we can help